Hello, it's a pleasure to me to speak to you today about reduced drug regimen and implication for resistance. Here are my disclosure. There have been changes in recent guidelines, and now 2-drug regimens are part of recommended or preferred first-line regimens. Concerns that I will discuss in this presentation are what is the rate of selection of resistant at failure in naive patients and virologically suppressed patients, and what is the impact of previously selected and archived resistance on virological response in patients with suppressed viral load switching to 2-drug regimen. First of all, what is the rate of resistance selection at failure in naive patients treated by 2-drug regimen? There is not a lot of data, but emergence of resistance mutation is very rare in DTG plus 3TC clinical trials in treatment-naive patients up to week 24 or 48, with the example of PADL, ACTG 5353, or Gemini. Or whether recently at the HIV Glasgow 2020 meeting, selection of resistance-associated mutation was reported in one patient in the DTG plus 3TC arm from the Gemini trial, which compare DTG plus 3TC versus DTG plus tenofovir FTC in first-line regimen. This patient had reported difficulties in adherence, had a baseline HIV RNA around 1,000 copies per milliliter and CD4 around 400. M184V mutation was selected at week 132, and the R263 RK mutation was selected as a mixture at week 143. Now, what is the rate of resistance selection at failure in virologically suppressed patients treated by 2-drug regimen? In SWORD studies, which the objective was to compare the efficacy of DTG plus rilpivirine versus standard triple regimen in patients previously treated and harboring a fully suppressed viremia, overall non-inferiority was demonstrated. And in DTG plus rilpivirine arm, 10 patients experienced virological failure between day 0 and week 100. There was no emergence of mutation to INSTI, or whether there was a selection of resistance mutation to NNRTI found in 3 out of 10 patients, the case 101E, the E138A, and the M230L. In the randomized, multi-center, open-label, non-inferiority studies, Atlas for experienced patients and FLAIR for naive patients, that compare cabotegravir plus rilpivirine long-acting versus current ART or DTG, abacavir, and 3TC. In case of virological failure, there was a high rate of emergence of resistance to NNRTI in both studies and to INSTI in the FLAIR study. In Atlas 2M, comparing administration of cabotegravir plus rilpivirine every 4 or 8 weeks, high rate of resistance at failure in both arms was evident. In the 8-week arm, 5 patients with confirmed virological failure had pre-existing major rilpivirine arms, 1 patient had a pre-existing major integrase inhibitor RAM, and 5 out of 8 patients had the L74I polymorphism. 3 were subtype A or A1, 1 subtype C, and 1 had a complex subtype. Last week, at HIV Glasgow 2020 meeting, multivariable and baseline factor analysis across Atlas, FLAIR, and Atlas 2M phase 3 study were presented. And in these analyses, 4 factors were associated with an increased odds ratio of confirmed virological failure. Among them, 3 were baseline factors, rilpivirine resistant associated mutation at baseline with odds ratio of 37, baseline HIV subtype, A6 or A1 with odds ratio at 6.5, and BMI with odds ratio at 1.13. The 4th parameter was the rilpivirine concentration at week 8 with odds ratio at 4. What is now the impact of archive resistance on virological response to 2-drug regimen? In the TANGO study, which is a switch to dolutegravir plus 3TC versus continue current ART in patients with stable first-line ART with TAF-FTC plus PI, NRTI, or INSTI, historical genotypic resistant report was not required in this trial for study entry, but participants with identified historical major NRTI or INSTI resistance associated mutation prior to randomization were excluded from the study. HIV proviral DNA genotyping analyses were conducted retrospectively on baseline sample using NGS platform assay, reporting resistance mutation at frequency of 15%, of more than 15%. Overall, prevalence of archive major resistance substitution was around 25% and around less than 10% for NRTI. Prevalence of INSTI major mutation was below 1%, and pre-specified integrase inhibitor substitution was around 25%. Irrespective of presence of major RAM or pre-specified integrase inhibitor substitution, similar high suppression rates were observed across both treatment groups. So, in conclusion, the rate of resistance selection in case of virological failure with 2-drug regimen is low in randomized clinical trials for DTG plus 3TC, intermediate in study for dolutegravir plus rilpivirine, and high for long-acting cabotegravir plus rilpivirine. Impact of archive resistance selected at time of previous virological failure seems to be moderate in DTG plus 3TC regimen. Finally, I would like to thank all the people working with me at Bichat Bernard Hospital and INRS and SIDAction, and I thank you all for your attention.